Welcome to Medicaid expansion and state tobacco cessation coverage. Before we begin, as a reminder, at the bottom of your screen there are multiple application widgets you can use. All of the boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in background that could cause issues. For the best audio quality, please make sure your computer speakers or headset are turned on and the volume is up so you can hear the presenters, and to make sure the media player on your screen is enabled. If you have any technical difficulties during the webcast, please let us know via the Q&A box. If you have any questions during the webcast, you can submit them through the Q&A box. This webcast is being recorded and will be available tomorrow and can be accessed using the same link you used to register. And now we'll begin the webcast, and I'll turn it over to Ann DiGiulio, National Director for Lung Health Policy for the American Lung Association.
Thank you so much, and welcome everyone to today's webinar, Medicaid Expansion and State Tobacco Cessation Coverage. So today we're going to explore tobacco cessation treatment coverage and state Medicaid expansion programs. But before we start, just a couple of housekeeping notes. Again, you can move around any of the boxes, so feel free to do that. If you have any questions at any time, whether they be technical or substantive, please feel free to put them in the Q&A box at the bottom of your screen, and you can pop that up. We'll answer all of the substantive questions at the end, and we've got a couple of people standing by to help you with any technical challenges you might have. Additionally, after the webinar, you'll be sent an email thanking you for attending and providing you with a survey. We would appreciate you taking about 3 minutes to fill out the very quick survey. We want to make sure that the data we present is helpful and the presentation that we give helps further our tobacco control work that we're all doing. So if you could please do that, that is my only ask of you. And so let's enjoy the webinar. So today you'll be hearing from me, Ann DiGiulio. I'm the National Director of Lung Health Policy here at the American Lung Association. I direct our tobacco cessation policy project, which includes collecting tobacco cessation coverage in state Medicaid programs, which we'll be talking about today, and also working on our efforts around tobacco cessation and technical assistance. So please feel free to reach out with any questions. I'm also joined today by Hope Avalone, our graduate intern of health policy. Hope is currently pursuing her master's in public health at the George Washington Milken Institute School of Public Health. She worked on collecting the data that we'll be talking about today, so we really owe her a great debt, and she's the reason we're having this presentation. So kind of just a quick overview of what we're going to be talking about. So we'll give you a quick background on Medicaid expansion as well as tobacco cessation treatments and different coverage requirements. Then we're going to talk a little bit about the methodology we use to collect the data, talk about the actual data that we collected, and then have a discussion, and we'll have plenty of time for questions and answers at the end. So please, again, use that Q&A box throughout the presentation. I'm going to start out with the background. Everybody, I'm assuming on the call, knows the high burden that tobacco causes in the United States. Almost 500,000 people die every year from cigarette smoking, and more than 16 million Americans are currently living with a disease caused by smoking. And then in addition to that, we know that there's not only in the terms of the cost of life, there's also a pretty significant economic cost. And we also know that a decrease in the smoking rate can really result in savings to state Medicaid programs specifically, but also to the population overall. A recent study found that a 1% overall decrease in the smoking rate would lead to a $2.6 billion decrease in Medicaid expenditures in the next year. So really helping people quit will not only help save lives, but it's going to help save money as well. So before we kind of get started, just so we're all on the same page, so we know we've got the same idea of what a comprehensive tobacco cessation benefit is, and this is defined by the Treating Tobacco Use and Dependence 2008 update. This is the most recent update we have on this. There are 7 medications that are FDA approved and have been found safe and effective in helping smokers quit. There are the 5 NRTs, or nicotine replacement therapies. They're the gum, patch, lozenge, nasal spray, and inhaler. Additionally, there's bupropion, which is also sold as Zyban, and varenicline, which is sold as Chantix. In addition to those 7 medications, there are also 3 types of counseling that are found safe and effective in helping smokers quit. Individual and face-to-face counseling, so that's when an individual speaks with their provider. Group counseling, that can also be considered a class or a group session. And then phone counseling or quit line coverage. Around the medications, the nicotine gum, patch, and lozenge are all over-the-counter medications, while the others require a prescription. As we get a little bit further on, we're going to talk about no cost sharing for all of these medications. To get no cost sharing, an individual would need a prescription from a provider, even for those over-the-counter medications. So that's the gum, patch, and lozenge. Additionally, to looking at what treatment is available for helping people quit, we also like to look at the barriers to access and kind of what are the hurdles that people have to jump over. And so I'm going to kind of talk through them. So first is cost sharing. This can be the co-insurance, deductible, or co-pays. Specifically for the Medicaid population, this can pose a barrier just due to the definition of Medicaid being a low-income population. Prior authorization, so needing an additional authorization from the insurance company or the Medicaid managed care plan or the Medicaid plan, in addition to the prescriber writing the prescription. Additionally, we see duration limits, so a person can only be on a medication for 60 days, might be an example of a duration limit. And again, this can just, maybe that individual needs more medication and kind of really interferes with the patient-provider relationship. We also see yearly or lifetime limits. Lifetime limits we see pretty sparingly, but we still see them, and that's you might only be able to quit once or twice over the course of your lifetime while you're insured by this specific organization, either the insurance company again or that Medicaid managed care plan. More commonly, we see yearly or annual limits. These limits could be, you can quit once per year or maybe once per 2 years. And so that also can just pose a barrier for somebody to quit. You might be more motivated to quit later in the year. Maybe you're expecting a baby, so you want to quit smoking, or you're going to be an uncle for the first time, and it just really kind of doesn't allow for a person to quit when they're ready and poses these artificial barriers. The next one is dollar limits. We see these more in private insurance plans than in Medicaid plans, but we'll give this patient $500 to quit for the course of this year. And so that really, again, limits what the provider and the patient can decide is the best option to quit for them. The next thing is stepped care therapy. So this means you might have to fail on one medication before trying another. All the 7 medications I mentioned earlier are all considered first-line treatments, so there's no clinical reason to have this stepped care therapy. It's purely an artificial barrier. So somebody may have to try and fail on the gum before they can get the patch, for example, or try and fail on the patch before they can get bupropion. And again, really, this is just not necessarily what the best option is between the patient and the provider. That's really where the decision should be made, especially considering that these are all first-line treatments. Lastly is required counseling, and you might be scratching your head to say, why is requiring counseling a barrier to accessing cessation treatment? And so while we know that the best way a person has to quit is to use a combination of both medications and counseling, we also know that for certain populations, accessing counseling can be challenging. So specifically for the Medicaid population, again, by definition, a low-income population, that might have limits on the number of minutes on their phone. So they've got to call the quit line to get that counseling. That might be using those precious minutes that they need to call their family. Potentially, if they need to go to a specific location to get individual counseling or attend a group counseling or a class session, there could be challenges with transportation costs and logistics, in addition to childcare and logistics. So really, kind of while we would encourage an individual to have both both counseling and medications, we don't want to necessarily discourage someone from quitting by having that barrier there. The one interesting thing kind of still in the background is that we really do see a higher burden of smoking in certain populations, specifically in the Medicaid population and the uninsured population, and then also in individuals below the poverty level, as well as some other populations. But I just wanted to flag that this is really an area where there is some need. So what is required? So the Affordable Care Act requires any A or B service rated by the United States Preventive Service Task Force to be covered without cost sharing for certain plans. And that includes almost all private plans, including any plan sold in the exchange, small group plans, most individual plans, and Medicaid expansion plans. And Medicaid expansion plans is what we're going to be talking about today, hence it's highlighted. There are different coverage requirements for Medicare, for standard Medicaid plans, so non-expansion plans, for grandfathered health care plans, and then for short-term limited duration plans. But we won't be going into those because really Medicaid expansion is what we're here to talk about today. So again, the preventative services requirement, any service given an A or a B grade by the United States Preventative Services Task Force has to be covered without cost sharing. And so the tobacco cessation gets an A grade, which is really good, meaning that it should be covered by those plans I mentioned, which includes these Medicaid expansion plans, without cost sharing. And so the Preventive Services Task Force, the United States Preventive Services Task Force releases these clinical guidelines so providers know what they should be doing and what they should be covering. And that doesn't really necessarily easily translate into how insurance companies write coverage documents and create formularies. So in May of 2014, the United States Departments of Labor, Treasury, and Health and Human Services issued an FAQ, which is a sub-regulatory guidance, and I like to think of it as kind of a way that the departments translated the clinical guidelines into insurance coverage language. And so they made it pretty simple and pretty clear that how these agencies would consider what a comprehensive benefit to be would be a tobacco cessation quit attempt would include at least 4 sessions of individual, group, and phone counseling, and at least 90 days of all or any FDA-approved cessation medication when prescribed, and that's that when prescribed. And that would need to be covered at least twice a year, and there would be no cost sharing, and then there would be no prior authorization. Again, the cost sharing is in the law, so this just reiterates that, but it makes it pretty clear what is supposed to be covered in theory. And again, it's implemented mainly by states, either state Medicaid departments or by state health insurance commissioners, kind of depending on where you're at. The United States Preventative Services Task Force updated its recommendation in 2015. They reiterated the A grade and found that both pharmacotherapy and counseling are effective in helping smokers quit. There was no new FAQ release, so the current FAQ still stands as the translation of what should be covered. So just to give everybody a little bit of background on some Medicaid requirements, just so everybody's got the same level settings. The Affordable Care Act did require standard Medicaid plans to cover all medications, but there's no counseling requirement. So that's one place where Medicaid and Medicaid expansion differ a little bit. And there's also standard Medicaid requirements are silent on barriers. So states still are allowed to impose barriers for that population, which again, it just puts another layer onto this data. Pregnant women on Medicaid are almost always going to be excluded from the expansion population because they were a population that was mandatory to cover prior to expansion. So that's not really in the population we're looking at, but just for everybody's knowledge, state Medicaid programs are required to cover a comprehensive cessation benefit for pregnant Medicaid enrollees. And that's very much written into the law with no cost sharing. It includes all the 7 FDA-approved medications and all 3 forms of counseling. So that is pretty clear, and you can look it up right there. I think it's section 1407, it's right there. So if you want to go Google after this webinar is over, you can do that. Now to talk a little bit just about Medicaid expansion in general. You'll see this map on your screen, and that shows where the Medicaid expansion states are. So just to read it real quickly, the states that are in green have expanded Medicaid since 2016. The states that have green lines on them, and that's Maine and Virginia, have expanded Medicaid since 2016 and are included in our 2019 data. Idaho and Nebraska are the 2 states that are in purple. We consider them Medicaid expansion states. However, they have not yet implemented expansion. Both states had ballot initiatives passed in 2018 that expand Medicaid, and they'll start enrolling people sometime in 2020. Idaho for January of 2020, and Nebraska will start enrolling people in the fall of 2020. So their data not collected in those 2 states due to the fact that there's not data available yet. Again, Medicaid in general is a healthcare coverage program for low-income Americans. Medicaid expansion is part of the Affordable Care Act, which requires people to be covered kind of wherever a state's Medicaid program left off to 138% of the federal poverty level. Unlike previous Medicaid programs, Medicaid expansion doesn't have any other requirements. It's just a financial one. So an 138% of the federal poverty level, because that number doesn't really mean anything, is $29,435 a year for a family of 4, which is $2,453 a month. $453 a month for a family of 3. So it's $29,435 for a family of 3. And then for an individual, that's $17,236 a year for an individual, or $1,436 a month for an individual. So we're talking still pretty low income, but you can be a childless adult, which most Medicaid programs, there's a number of Medicaid programs that exclude childless adults from coverage. You don't have to, and so there's nothing else that you have to prove, just that income threshold, which is unique and a newer feature for the Medicaid program. Due to a court case, Medicaid expansion is optional for states, so they don't have to. That's why they're the gray states that still exist. However, I will note that the gray states still have people that would fall under this threshold, and there are coverage gaps for those people. Additionally, the federal government picks up more of the cost of the Medicaid expansion program than it does for a standard Medicaid program. Normally, the federal government picks up anywhere from about 50 to about 73% of a state's Medicaid expenditure. For the Medicaid expansion population, the first year it picked up 100%. That is slowly, over the course of the current decade, going down to 90%, and then will be 90% in perpetuity. So the federal government is picking up a pretty decent chunk of this tab. Additionally, the Medicaid expansion programs are required to cover the essential health benefits, which include preventive services, which include tobacco cessation coverage. So that is a really great benefit that this program has, rather than other ones. So there are currently, if you haven't counted yet, there are currently 35 states in the District of Columbia that have expanded, which means there are still 15 states that have not expanded. Kind of what do we see in the Medicaid expansion population? We know that Medicaid enrollees overall, including expansion enrollees, smoke at a significantly higher rate than than privately insured individuals. It's estimated that approximately 7.9 million adult smokers are enrolled in Medicaid. And about 11% of Medicaid expenditures are attributable to smoking. So really, this is not necessarily a golden bullet, but we can do a lot by really helping this population quit smoking. And then lastly, before we talk on the data, I just want to give everybody a couple of new trends that we're seeing in state Medicaid programs. So, we've seen 4 states that have expanded Medicaid since we've last looked at this data, which is really exciting. There's a couple of potential reasons why. Over the past few years, Medicaid expansion's gotten much more popular. Part of that is for bad reasons. We've seen more rural hospital closures and a number of other factors that have made Medicaid expansion look more favorable to states. Additionally, and we'll talk about this a little bit later, is we're seeing really good health outcomes in states that have expanded Medicaid compared to their counterparts. So we're seeing just a lot of different trends in the Medicaid program, and we will continue to see those going forward. And so now I'm going to turn it over to my colleague, Hope, to talk about the methodology and the data.
Okay, thanks, Anne. So I'm just going to start by talking a little bit about the data that we collected and how we collected it. For this report, we collected data on 9 tobacco cessation treatments. These include the 7 FDA-approved medications, including 5 NRTs, or nicotine replacement therapies, and both bupropion and varenicline. And treatments also included 2 types of counseling, so individual and group. We also looked at 7 barriers. They were cost sharing, prior authorization, counseling requirements, step care therapy, and duration, annual, and lifetime limits. So as far as our data collection process, our information was collected on each plan available to Medicaid expansion enrollees in each expansion state. We searched Medicaid and managed care websites and documents, including preferred drug lists, formularies, handbooks, coverage policies, and prior authorization guidelines. We then categorize the data under 4 values, and these values can be found in the state-specific data section of the report, but the 4 values are yes, no, not available, and blink. So yes indicates that states covered a specific treatment for all Medicaid expansion enrollees, or that states imposed a specific barrier for all enrollees. A no indicates that states did not cover a specific treatment for any enrollees, or that states did not impose a specific barrier on all enrollees. A value of varies indicates that states covered a specific treatment for some enrollees, or that states imposed a barrier for some enrollees. Not available simply indicates that data were not available for that state. And finally, a blank value indicates that Medicaid expansion was not yet implemented at the time the data was collected. So once we collected and categorized the data, we then confirmed them with state contacts. And then we were able to compare our 2019 data with data we collected in 2016, which were previously published in the Morbidity and Mortality Weekly Report. Our data do have some limitations. While 35 states and BC have expanded Medicaid, data were not available for Idaho and Nebraska, as Ann mentioned, because they are not beginning to enroll individuals until 2020. So our report reflects data on 33 states and BC. And while we were thorough, we could only go by written documentation of coverage. So there is potential for the documentation to be outdated or for the data to have changed since we collected it in the spring. And finally, we did not collect data on phone counseling coverage for this project because of its complexities, and we also did not collect that data for 2016. So now just getting into the data, these are a few different highlights. Just a reminder that each of these numbers include states that offer these benefits to all Medicaid expansion enrollees. So as far as coverage, 11 states covered all 7 medications and 2 types of counseling. And those were all of the treatments we considered in our report. 23 states, the majority, covered all 7 medications. And 22 states, which is also a majority, covered individual counseling. That number was a little bit lower for group counseling at just 14 states. Regarding barriers, only 1 state, Kentucky, did not impose any of the 7 barriers we considered. And then we also focused in, for this slide, on co-payments and prior authorization, because they're both specifically mentioned in that tri-department FAQ that Ann discussed earlier. So 22 states do not require co-payments, but only 9 states out of the 34 that have expanded do not require prior authorization. And all of this data on coverage and barriers is available and broken down by state in the charts at the end of the report. So now I'm going to get into that comparison piece so we can see how coverage has changed in states that have expanded Medicaid between 2016 and 2019. There have been some changes in coverage between these 3 years. More states are covering medications, but there's still a lack of states covering all medications and counseling, and there's still a lack of states covering group counseling specifically. Also, our data show that no states had barrier-free access to cessation treatment in 2016, but as we mentioned in 2019, only Kentucky has barrier-free access. And again, this is just a reminder that you can find these state-specific data on coverage and barriers in the report. So now we're going to get into some visuals just to give an idea of where Medicaid expansion is happening and where cessation treatments are being covered. This first map shows which states covered all 7 medications in 2016. Expansion states, again, are in all green. The striped states are those that cover all 7 FDA-approved medications. And as you can see, that was actually the majority of the expansion states in 2016. And here is that same map for 2019. We can see that more states have expanded and more states cover all 7 medications. In this map, Idaho and Nebraska are in purple because, as we mentioned, they have not yet implemented expansion. And then going back to 2016, this map shows which states cover all 7 medications and both types of counseling, so all the treatments we considered. And there again were only 9 states that offered this benefit in 2016. And then looking at that same map, switching to 2019, we can see that the number of states covering all medication and counseling increased by 2 since 2016, so that's 11 states. And this chart kind of breaks down coverage by treatment and really portrays the change over time between 2016 and 2019. Anything in green here represents data from 2016, and anything in blue represents data from 2019. And you can see that coverage of NRTs, or nicotine replacement therapies, has increased significantly. This also shows that less states cover counseling than they do medications, despite the fact that the number of states covering group and individual counseling did increase between 2016 and 2019. And there's also a few more things to point out here. An interesting and very positive finding is that at the time of collection, all expansion states covered NRT gum, the NRT patch, and bupropion for all Medicaid expansion enrollees. So you'll see that 34 value in the chart underneath. It's also important to note that between 2016 and 2019, we did see more states expand Medicaid, so our N did change from 32 states to 34 states. But the improvement we see is not just because there are more expansion states, but because coverage is actually getting better in the states that have already expanded. And then this last chart just breaks down the number of states without each of the 7 barriers for all Medicaid expansion enrollees. Overall, less states imposed barriers in 2019 than in 2016, and we see the biggest changes for annual limits, prior authorization, step care therapy, and copayments. And again, all of these state-specific data for 2016 and 2019 can be found in the report. But now that we've looked at the data, I'm going to turn it back over to Anne so she could talk a little bit about what all of this means.
Thanks, Hope. And the one thing I failed to mention earlier is you can find both the current report and the 2016 MMWR article in their 2 PDFs in your resources file or documents folder, which is one of the widgets on the bottom of your screen. So you can access those if you haven't seen those yet. So now I'm going to talk about what all that data means. So I think some of the key takeaways are that Medicaid expansion programs are really improving their coverage, and all state Medicaid expansion programs are covering at least some treatment for all expansion enrollees. But unfortunately, the majority of states still don't cover all the treatments, and they lack access to medications and counseling. There are still a lot of barriers to accessing these treatments, and that I think is one of the bigger takeaways, that there's still a lot of barriers even though coverage is improving. And then again, the other key takeaway is still all that gray that we see, in that there's still so many states that haven't expanded. The other thing, and this is my favorite slide, I think, and this is just highlighting some other research that other people have done. And there are a few studies published recently that show that not only are states expanding their Medicaid program, and not only are states improving coverage of their cessation treatments, people are actually using the treatments. The second 2 studies from May both show that they both compared information from states that have expanded Medicaid versus states that haven't expanded Medicaid, and have found that that Medicaid enrollees are more likely to have a quit attempt or use a cessation treatment in states that have expanded than haven't expanded. So this is kind of really gets to the heart of it. Not only are states covering these treatments while they could do better in places, but people are using them. So if we can improve the coverage and get rid of some of the barriers, these numbers could even increase more. And then that top study that we referenced, that JAMA one from April, really just shows that 1% decrease in smoking prevalence leads to the $2.6 billion increase in Medicaid savings. So that's just a really cool thing, and really that doing the right thing in this case by covering cessation treatment really has an impact on the population. I think we still know that there is more to be done. There are more states that can expand Medicaid. There are more, in states that have expanded Medicaid, there's more to be done in removing barriers, except if you're Kentucky. There's more to be done in improving coverage. And then even if you've done all of that, you can still promote the benefit and still help people connect to get that and help them quit. Now I'd like to share some resources, and again, we have both the report and the 2016 MMWR available to download in that file, so would encourage you to look at that. Additionally, the Lung Association has a number of resources. We've got our resource library on lung.org/cessation TA. We also we've got a number of listservs that we have that you're all more than welcome to join, and you might already be on because you've gotten information about this webinar. We also provide one-on-one technical assistance, so please feel free to reach out. We have a number of toolkits, fact sheets. We are currently in the process of updating our Assisters toolkit, so please stay tuned for more information on that. And now we've got a lot of time for some questions. My contact information is up there, so if you've got additional questions please that we don't get to today, please feel free to reach out. Additionally, all the state-specific information that Hope has referenced is in the report, so please feel free to look at that. And if you've got any questions, if you want to type them into the Q&A box, and we'll just give everybody a minute right now.
Yes. So the first question, do you have any tips or advice for a state health department or another stakeholder interested in working with their Medicaid office to improve the cessation benefit in their state?
So I think the first thing you did was talk about working with your Medicaid office. And I think the best thing you can do is, one, first figure out what your Medicaid coverage is. And so for the Medicaid expansion coverage, that is in the report that we have, and that is on there. The Lung Association also collects standard Medicaid coverage, so that's another good place to start, but to look at that first. And then to go in to work with partners. The public health departments are a really great partner. There are local lung associations across the country that are ready to partner with you to help work and to help improve that, and then to also start partnering with the Medicaid office and to really start building those relationships.
Great. We have another question about the medications. A lot of the NRT, nicotine replacement therapy medications, are available over the counter. So we're wondering why it matters if they're prescribed by a provider or if they're explicitly covered by Medicaid.
Yeah, so especially in the Medicaid population, again, it's a low-income population, and if they are covered by the state Medicaid program and prescribed by a prescriber, the individual can get that medication without cost sharing or with very low cost sharing. So that's the main reason to be able to do that. Okay, so we had another question come in.
It is the cost impact of lower prevalence more granular than the national level, either by state or by communities?
Yeah, so I think you're referring to that number of the 1% decrease in smoking rate. It equals a $2.3 billion decrease in Medicaid savings over the next year. That data is also that's broken out by state level, and you can find that on JAMA's website.
Great. So you mentioned that the USPSTF guidelines inform Medicaid expansion coverage. How often is the USPSTF Preventive Services guidelines updated?
Yeah, so the United States Preventative Services Task Force guidelines, they're updated on a periodic basis, I would say is the best way to describe it. Currently, they're updating their youth prevention and cessation guidelines, but we will see when the next time they update their adult cessation guidelines. But I'm sure that will be publicized if and when they do.
Great. So we have another a question and also an observation. One of our participants has found that people who have insurance through their employer often also have a high cost for prescription drugs, which creates another barrier to these treatments.
Yeah, so while most employer plans should be following that United States Preventative Services Task Force guidelines and requiring and covering cessation medications, and any United States Preventative Services Task Force A or B preventive service without cost sharing, there are still about 17%, or I think it's about 17% of employer-based plans that are still grandfathered, so that they would not necessarily have that requirement. Additionally, only how good that provision is enforced. So if somebody is in a situation where you're running across patients that have private insurance and you think they shouldn't have a copay or co-insurance for their cessation medications, a good place to start is the insurance commissioner, especially for private insurance. Medicaid, talk with the Medicaid office, but private insurance should be the insurance commissioner.
Okay, thank you. Another question, are some barriers to treatment worse than others? Do some pose more of a restriction on access to the treatment than others?
That's a great question. I think some of them, so personally for me, I think probably the worst one is lifetime limits. I think that's a pretty objective one, that you can only quit so many times in your lifetime. On top of that, I think sometimes the combination of them can be really bad. So, you know, if you have only 4 quit attempts per year, but you, but say you've got a prior authorization, but you've got a stepped care therapy and you need to try the NRT gum before you can try varenicline, and you switch from a different managed care program last year where you tried to quit with the NRT gum, you're going to then have to retry to quit with the NRT gum before you can get varenicline. And you might run out of quit attempts, and it's just really bad for the motivational aspect of trying to quit and really kind of doing something that's very difficult to do. We know tobacco is a really intense addiction, and we want everybody to, we believe that everybody can quit, but we really need to make sure that everybody has the tools to quit.
All right, another question. Are there resources for health professionals on what is covered by Medicaid expansion, Medicare, and private insurance by state for tobacco cessation treatment to help them guide patients on what to expect for coverage?
Yeah, so a little bit. So there are state and federal regulations on what is supposed to be covered. Medicaid, again, that's going to be a state-by-state basis. While we do know that, you know, all Medicaid expansion programs are required to cover all 7 medications and all 3 forms of counseling, we know that that's not the case. That's what our data show. We also know that that's true. You know, Medicaid's not covering necessarily to the extent what the federal law says they should. All that being said, I think the best way to, and same thing with, we have not looked at private insurance coverage in a while, but the last time we did look at private insurance coverage, that rang true. Medicare is a national coverage determination, so Medicare plans don't cover any over-the-counter medications, kind of as a rule of thumb, but there's varying cost sharing with Medicare. The best way as a provider to know, and you're going to hate me for this answer, the best way as a provider to know what's covered is really to look at the plan-specific documents that a patient has. If your patient population is generally the same, it has similar insurance, you hopefully could get into a rhythm of kind of knowing what's covered and what's not. But it's really best to look at that plan-specific information because it really does get very granular.
Thank you. So is there a specification for the length of each counseling session that is covered through Medicaid?
Thanks, that's a great question. So one of the things that the Lung Association collects data, we are not brand specific in the medications we collect, just if anything's covered. Additionally, with counseling sessions, we look at both the short, brief counseling sessions and the long counseling sessions. If at least one of those codes is covered, then we consider them having individual counseling covered. Group counseling, it would either be a class or there's a different code for group counseling. So it would have to at least be a brief intervention, which would be that 3 to 5 minutes, but we don't necessarily differentiate between the 2 different types of counseling, 2 different lengths of counseling. And if you're unaware, there's kind of 2 different procedure codes for cessation counseling. One's a brief intervention, one's an intensive intervention. And so that's kind of from a medical perspective and from a medical coding perspective, those are the 2 types that exist. And so really kind of just which one is covered, and there are pros and cons to that. So.
Great. Another question that's come in. How does the coverage data for Medicaid expansion compare to the data for standard Medicaid?
So this report doesn't look at the comparison of both of those data. We do know that there's a couple of different ways states have expanded their Medicaid program. Probably the most common way states have expanded their Medicaid program is to just put everybody together. So if you get your standard Medicaid enrollee, or if you're a Medicaid expansion enrollee, you're enrolled in the same program, you get the same benefits, and the idea would be that they bring the coverage up to make sure they're covering everything that they're supposed to in both for standard Medicaid and expansion. So that's one option. So those states would have similar same Medicaid coverage. There are some states where, because Medicaid expansion has different requirements, including the essential health benefits that the standard Medicaid program doesn't have, that will create a separate program. So, for example, maybe they'll have Medicaid Part C for the expansion enrollees. And so they enroll in, excuse me, they're enrolled in a slightly different program. Maybe it's called Healthy State Program versus like just the regular program or whatever. And so then they would get a separate set of benefits. And in that case, you could see some variability, and that does exist in some states. The third option that states have done, and really it's just Arkansas that does this now, New Hampshire had done it for a while, was they provide Medicaid expansion enrollees funds to buy health insurance through the exchanges, and then they make that, then the state also covers any of the cost sharing and other costs and provide some wraparound services to kind of make that enrollee whole and make sure they have all the benefits that a Medicaid expansion enrollee would have. So that would also have some differences. But for the most part, we know most states are expanding just by putting everybody in that same clump. But again, we don't have specific data on that.
I just want to remind people, if you have state-specific questions, it'd be great if you could start by reading the report and then following up with Anne if you have additional questions after that.
And we'll just, one last pause for questions. I know there are a couple of state-specific questions that came in, but we will get, we'll be able to answer them with you individually later. Okay, and with that, I just want to thank everybody again for joining today's webinar. And remind everybody to please take the survey that you'll get at the email after this. And then lastly, you can download the report and the 2016 MMWR article from this platform right now. And so I will turn it back over to our presenters. I think it was Regina.
Ladies and gentlemen, this will conclude today's meeting. Thank you all for joining, and you may now disconnect.